Hi everyone, we're going to talk about epilepsy here, and epilepsy is part of a wider spectrum of classification of seizures. So not all seizures fall into the category of epilepsy. We're going to focus primarily on the disease of epilepsy, the syndrome of epilepsy. We'll talk about status epilepticus, or the acute treatment of seizures, in another section. Okay, so epilepsy is a disorder that affects about 1 in 200 persons in the U.S., so that's about 0.5%. Globally, it affects about 1% of all people by age 20 and about 3% by age 75. So quite a few people will actually go on to develop epilepsy in their lifetime. You probably know somebody who has epilepsy or who has had a seizure before. Now, epilepsy you can think of as the chronic condition of recurrent seizures. So not everybody who has a seizure or who has had a seizure has epilepsy. Epilepsy is the chronic condition of having seizures, recurrent seizures. So a single seizure does not diagnose epilepsy, and a single seizure does not necessarily mandate treatment for epilepsy. Seizures are a lot of times preceded by an aura, which is defined as a sensory experience that is oftentimes correlatory to the epileptic event, and a lot of times it's unique to that particular patient. So a particular patient who has epilepsy will a lot of times experience this same sensory manifestation before a seizure every time. So, and it'll be unique to that patient. So there are a lot of different kinds of auras that can precede seizures, and not necessarily every patient has an aura before a seizure, but there are different kinds of auras. So some include somatic sensations, like a rising epigastric sensation, sort of that feeling you get when you go down a roller coaster. There can be various hallucinations, so visual hallucinations, gustatory or olfactory hallucinations, which are getting the sensation of a strange smell or a strange taste. You can have visual changes, so you can experience those halos that you see sometimes in your eyes, or you can see zigzags. Some people complain of headaches. Some people have paresthesias, so they feel numbness or tingling in a certain part of their body. And some patients have psychiatric phenomena like deja vu or jamais vu, which is that sensation you get when you feel like you've been in that scenario before. Really, I guess, kind of difficult to explain, but various psychiatric phenomena can be defined as an aura if they're correlated to the epileptic event. So it's not unusual to have a patient describe a certain feeling or a certain sensation come on before they have their seizure, and that is what's called an aura. And not all patients with epilepsy have auras. There are certain conditions that can trigger seizures, so and this would be in most patients with epilepsy, but certain patients, they're more inclined to fall victim to certain triggers than others. So some triggers could be sleep deprivation, emotional stress or physical stress, alcohol or alcohol withdrawal, which usually alcohol withdrawal would cause a form of seizures called delirium tremens, which doesn't really technically fall under epilepsy. But those can be certain triggers, and there are more. Those are just some examples. Tonic-clonic seizures, which we'll talk about what those are specifically, are often followed by a temporary post-ictal state of somnolence. So by post-ictal, we just mean post-seizure. So after they come to out of their seizure, a lot of patients with the convulsive seizures will be tired for up to 24 hours after their seizure. That's not uncommon. And sometimes it can also be followed by a temporary physical paralysis or a cognitive impairment, and that's known as Todd's paralysis. So it's a temporary period of time where they have an impairment, either physical or cognitive, following their seizures. So some epilepsy terminology. There's a lot of words thrown around when you're talking about epilepsy, and it's really important to have a handle on what those words are so you understand not only what's being described, but how you're going to treat that epilepsy and how you're going to diagnose that epilepsy, because that's going to play a role in what medications you prescribe, if any. So we define seizures as either partial or generalized. So the best way to think of partial versus generalized is that a partial seizure occurs in just a specific part of the brain, whereas a generalized seizure occurs bilaterally in the brain as a whole. So a partial seizure can be thought of as like a focal seizure, and it occurs and affects one discrete part of the brain and often involves an automatism or a tic. So it could be a jerk, it could be a reflex, it could be lip smacking. And we define partial seizures, we break down partial seizures as either simple or complex. So a simple seizure involves no alteration of consciousness. You're aware of what's going on while it's happening. A complex seizure involves an alteration of consciousness. It may not be a total loss of consciousness, but there is some alteration of consciousness. So that's simple versus complex, and it's just a way of differentiating two different types of partial seizures. Now, a generalized seizure, as mentioned, occurs and affects the brain as a whole. So in most cases, a generalized seizure is going to involve a degree of alteration of consciousness, but there are various degrees, of course. So generalized is a bilateral effect. It's a bilateral seizure, so you would note that on EEG. You would see it on all the leads. And there are various types of generalized seizures, and you would differentiate these seizures based on how they appear when you're observing them. So there are the so-called absence seizures or petit mal, and these are generalized seizures that involve a sudden brief loss of consciousness. A lot of times it appears as a staring into space, and it only lasts seconds. Usually this is diagnosed in children, but it can be diagnosed in adults, and it can continue into adulthood. But oftentimes it'll be noted by a teacher that the kid is not paying attention or they're suddenly staring into space. And what this is a brief loss of consciousness. Now, this is a generalized seizure. Even though it can appear to be a partial seizure, it is a generalized seizure. There is a loss of consciousness, and there is an automatism, and it is generalized to the entire part of the brain. And this is an important diagnosis because absence seizures has a very specific treatment that we need to give if it is an absence seizure and not a partial seizure or a different type of seizure. Now, the tonic-clonic seizure or grand mal seizure is the stereotypic type of seizure with the muscle rigidity and convulsions, and this is usually pretty easy to figure out based on looking at the patient. They're having that stereotypical body convulsions. This tends to last minutes, so that's different from some of the other generalized seizures. The myotonic seizures can be similar to the tonic-clonic seizures, but it tends to last seconds to minutes, and it's usually just brief muscle jerks as opposed to generalized convulsions. The atonic seizure is another generalized type of seizure, and it involves a brief loss of tone. And so this can be described as a drop seizure, and so it could be it can be confused with like fainting. So the patient could be standing up or walking, and suddenly they'll just fall down. But there's this does not last very long, so it can be differentiated from the tonic-clonic seizure in that this generally just lasts a couple seconds, and it can be differentiated from the myotonic seizure in that you don't have jerks. You can often hear the term secondary generalized seizure, and what that's referring to is a generalized seizure, so a seizure that involves both hemispheres of the brain, that originates from a partial event. So you can have a partial seizure that's just occurring in one discrete part of the brain, may involve an automatism or a tic, that turns into a generalized seizure. And that's usually how generalized seizures start. So most generalized seizures are indeed secondary generalized seizures. And if you look at the EEG, you would see an abnormality on one lead of the EEG, indicating that it's a partial seizure because it's only affecting one part of the brain, but then that immediately turns into a generalized seizure where it's affecting all parts of the brain. And that's just called secondary generalized. So you can think of it as generalized seizure secondary to a partial seizure. We just call that secondary generalized seizure. There's another type of seizures called febrile seizures, and these are a totally different animal. These are tonic-clonic seizures. They are convulsive seizures. They happen in children, but these are not epilepsy. So a febrile seizure occurs in children, usually young children, toddlers, and it coincides with fever, but they never happen when apart from a fever. So the child will have an epileptic, or child will have a convulsive seizure along with a fever, and when the fever goes away, the seizure will go away. Well, usually the seizure will go away before the fever goes away, but the most important part to febrile seizures is that it's in pediatrics and that the seizure always coincides with a fever. And febrile seizures do not require long-term therapy. You can abort the seizure with a benzodiazepine if necessary, but it doesn't require long-term treatment. And that is what makes it different from epilepsy, from the partial and generalized seizures. So it can't be overemphasized that history is of the utmost importance in evaluating any patient with suspected epilepsy. So any patient who has a seizure, you need to get a really, really, really good comprehensive history on the patient. So a lot of times that's going to involve asking observers, asking family members about what happens before the event, what they're observing, because a lot of patients who have seizures are not conscious while it's happening. So what's happening before the event? What's happening after the event? Are there any particular automatisms? And the reason that you need to figure out if there are any particular automatisms is that the automatism that is the aura or automatism that's being displayed may give you a hint to the focus of origination. So for instance, if the patient has a leg jerk before, or a leg paresthesia before they have a generalized convulsive seizure, that could tell you that the middle part of the brain responsible for leg sensation or leg motor control may be responsible for the generalized epilepsy. You may have a trauma, you may have a lesion in that particular part of the brain. So that's going to give you a hint as to what to look for when you do imaging, and ultimately you will do imaging. Another thing to ask about is if there's any history of trauma. So you may not have epilepsy, or you may not have a seizure disorder developing right after the trauma. It may be 3-4 years down the road. So you need to ask the patient, have they had any kind of head trauma in the past? Have they played any kind of high contact sports like football or soccer or hockey? Also, do they currently or have they in the past used drugs and alcohol? Like I mentioned with delirium tremens, you can get seizures from alcohol withdrawal. As I mentioned, also a witness is also useful for the history because a lot of patients with seizures are not conscious for the events. Otherwise, though, most patients are going to have an otherwise unremarkable clinical history. So patients with epilepsy are not, in general, any different than other people, other than they have their seizures. As far as symptoms, most patients with epilepsy are physically normal. They're asymptomatic between events, so your physical is not going to give you as much of a hint into what the cause of the epilepsy is, as much as your history is going to, because your average epilepsy patient is quite normal in between their events. However, if they do have symptoms, it does need to be noted because there are certain syndromes, particularly in children, that can give note to a syndrome that can cause epilepsy. So for the diagnosis of epilepsy, there's really no first initial best test to do on a patient who has had a seizure. In order to make the diagnosis of epilepsy, they need to have an abnormal EEG. So an EEG can be considered the best initial diagnosis in a patient, the best initial test for diagnosis in a patient that does not have any head trauma or any indication of infection or any fever. But certainly you do need to work up for possible other causes of seizures before going and getting an EEG. So you should always exclude external causes. And by external causes, I mean trauma, I mean fever, I mean tumor, I mean stroke, alcohol withdrawal, etc. You should always also get a CT on any patient with a seizure over the age of 30. So the reason for that is because it's very common that a space-occupying lesion, a tumor, can be the cause of a seizure in a patient with new onset seizures that's older. MRI is more accurate than CT, so that's going to be better at noting focal abnormalities of the brain. And of course, routine labs should also be ordered to rule out electrolyte abnormalities, metabolic abnormalities. CBC is important for to check for infection. Of course, you'll have other signs of infection besides that. But your routine labs are going to be useful too. So the four things you should be getting in any new seizure patient is an EEG, a CT, an MRI, and routine labs. But not necessarily in any order. The order is going to depend on their presentation. So the different causes of epilepsy or seizures can be remembered by this mnemonic, vitamins. So V stands for vascular malformation, which can be detected on CT and MRI. So this is how you're going to use those diagnostic tests. So CT or MRI can show you a vascular malformation, an infection or inherited conditions. So infection will oftentimes be documented on the physical and on the CBC, and as much as you'd have a high white count. Inherited conditions would be more in children, and that's going to follow with the history. Trauma, of course, is going to be history, and CT and MRI can give you any hints as to if there's some trauma as well. Alzheimer's disease can cause epilepsy. That, of course, is also going to be based on your history. Metabolic derangements, you'll note on your CMP, basically any kind of low electrolyte status can cause epilepsy, with the exception of probably potassium. So low calcium, low sodium, low magnesium, low glucose. Those can all cause seizures. Of course, epilepsy can be idiopathic, and then neoplasm is a very important one to remember, particularly in older patients. That you can note on the CT and MRI, and then psychiatric causes. Primarily what we're talking about there is psychogenic epilepsy, so the non-epileptic seizures, conversion disorder, or malingering, or Munchausen syndrome. So younger patients, you're usually going to be looking, depending on their age, febrile seizures if it's coinciding with a fever. If it's in a very, very young patient, you're not going to think of febrile seizures in a teenager. Juvenile myoclonic epilepsy, particularly if it's a myoclonic seizure, if it's that specific type of jerking, that tends to go away in adulthood, but it may go into another type of epilepsy, typically tonic-clonic seizures. Absence seizures are more common in younger patients. Infection, alcohol withdrawal, trauma, like in anybody. And then there are two particular types of pediatric syndromes that can be associated with myoclonic syndromes. And those are MRF, which is myoclonic epilepsy with ragged red fibers. That's a pediatric disorder, usually diagnosed around 3-4 years old. It's associated with short stature, hearing loss, visual impairments. And then Lennox-Gastaut syndrome, which is much more common than MRF. And that's another myoclonic syndrome that also involves developmental delay and mental retardation. In older patients, you're definitely thinking tumor first. So when I say older patients, I'm mostly talking like 30, 40 plus. So tumor, vascular disease or stroke, Alzheimer's, and then infection, alcohol withdrawal, and trauma. So these should all be part of your differential diagnosis as to the cause for a seizure. Some other things that should be in your differential diagnosis as to things that are not seizures but may appear to be seizures are migraine headaches. So those can give similar symptoms to the aura. So a lot of patients who have migraines will have that typical aura sensation, particularly visual symptoms. But patients with migraines do not have an impairment of consciousness, and they generally have a normal EEG. Patients with stroke, of course, will be older patients. Of course, 1 in 5 stroke patients are children or patients under the age of 30. But they're typically older patients. There will be findings on CT consistent with stroke. So you either see hemorrhage or you'll see change in the white matter of the brain. And then the impairment is going to last longer. So if they have that so-called Todd's paralysis after the seizure-like event, an impairment with a stroke is going to be more permanent or long-term. A febrile seizure, as mentioned, coincides with a fever in a young child. It does not require long-term therapy. It may require treatment in as much as you would need to abort the seizure with a benzodiazepine, but it does not require long-term therapy. Syncope can appear to be similar to an atonic epileptic event, but different from atonic epilepsy. With syncope, you're not going to have any post-ictal symptoms, and you will generally have a normal serum creatinine. The serum creatinine is a nice marker to look at to see if the patient really had a seizure, and certainly not all seizures are going to give you an abnormal serum creatinine, but an abnormal serum creatinine points to a seizure. So if a patient has a normal serum creatinine and there are whether or not they had a seizure is questionable, looking at that normal serum creatinine and seeing that may give you more evidence to that they didn't have a seizure. And that also will play a role in psychogenic epilepsy. So a normal serum creatinine will also point to a non-epileptic event. With psychogenic epilepsy, you should be really careful in making that diagnosis. It should definitely be one of exclusion. And I talk more about psychogenic epilepsy, Munchausen syndrome, malingering, conversion syndrome in the psychiatric lectures. Okay, so what do we do for treatment? First, we have to rule out all secondary causes. And by secondary causes, I mean metabolic derangements, tumors, etc. Once you've ruled out all secondary causes, the patient should be offered anti-epileptic drugs. Now, usually we don't give anti-epileptic drugs if it's the patient's first seizure. Why? Because they don't really have epilepsy if they've only had one seizure. The exclusion to this, the one exception, if it's their first seizure, is if it's status epilepticus, if the seizure lasted 30 minutes. If the seizure has lasted 30 minutes, then we definitely are going to give them anti-epileptic medication because their seizure was a life-threatening event. Another exception where you may start anti-epileptic drugs if it's their first seizure is if they have a really strong family history of epilepsy. As a personal note, my family has a really strong history of epilepsy. So anybody in my family who has a seizure, even if it's their first one, they're going to get started on an anti-epileptic drug. But in general, for the USMLE, if it's a patient's first seizure, you're not going to start them on anti-epileptic drugs. Certainly, you should be treating their seizure while they're having it. If they're 5 minutes into their seizure, you should be giving them a benzodiazepine. But you don't need to start them on long-term therapy if they've only had one seizure. All patients, however, who have had a seizure should get an EEG before or during the regimen. So even if it's their first seizure, they should be getting an EEG as part of their workup, in addition to CT, MRI, labs, etc. And then all patients with diagnosed epilepsy with an abnormal EEG should at some point have a 5 to 7 day continuous video EEG. So when I say that all patients who've had a seizure should have an EEG, by that I mean a short EEG, so like a 30-minute or 1 hour EEG. When I say all patients with epilepsy should have a 5 to 7 day continuous video EEG, that's a much longer EEG, obviously, and you're looking with video and seeing if there are any particular automatisms or behaviors that precede the epileptic event. So any patient, if it's their first seizure, should get an EEG, but all patients who have diagnosed epilepsy, abnormal EEG, should get eventually at some point a 5 to 7 day continuous EEG. Okay, so anti-epileptic drugs. Now, epilepsy is to neurology as high blood pressure is to cardiology and as depression is to psychiatry. And by that, I mean there are a ton of drugs. And treating the patient with epilepsy is more of an art form than it is a science, because it's a lot more of finding the right drugs, the right particular drugs, and finding the right dosage to get that patient controlled. Every patient is different, and this is a very, very, very heterogeneous disorder. So there is no strict rules to treating epilepsy. Different neurologists like to treat it differently. Now, there are some particular rules of thumb that are useful for real life and particularly for the USMLE. So if the patient has absence seizures, ethosuximide is the drug of choice. Always, 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 always. Okay? For the USMLE, it's always ethosuximide for absence seizures. Now, if they have simple seizures, then you're going to give them carbamazepine, particularly, or oxcarbazepine, lamotrigine, or topiramate are also good drugs for simple seizures or generalized seizures that have that are secondary to a simple event. So simple or secondary generalized seizures, carbamazepine is generally the drug of choice, but oxcarbazepine, lamotrigine, and topiramate can also be used. In general, for generalized epilepsy or epilepsy that you really don't know what kind it is, valproate is usually the drug of choice. And valproate is a very good, in general, valproate is a good drug if you just really don't know what kind of epilepsy it is. So if you're unsure, you should always know what absence seizures is just because of how they look. But if you're unsure of the answer, I would always go with valproate because it's good for the unclassified epilepsy, so it's hard to go wrong. Another two drugs that are good for seizures in general are lamotrigine and topiramate. They have a very broad spectrum of action. So the real rule I would know, though, is ethosuximide for absence seizures, and then know that valproate is good if you don't know what kind of epilepsy it is, and lamotrigine and topiramate have a broad spectrum of action. But it's really hard to go wrong with simple epilepsy and generalized epilepsy with any of the anti-epileptic drugs. There are some exceptions, but you're not responsible for knowing those for the USMLE, and that's just because usually it's a neurologist who's prescribing these medications. I mean, there are certain anti-epileptic drugs that you would never give in, for instance, a patient with myoclonic seizures, but you don't need to know this. Just know ethosuximide is a drug of choice for absence seizures. Lamotrigine and topiramate have broad spectrum of action. Valproate if you don't know what kind of epilepsy it is. Okay, I'm trying to make this as simple as I can without dumbing it down too much. Okay, a word on EEGs. So you may have been on rotations where you've had neurologists showing you EEGs and pointing out all different sorts of things. For the USMLE, you don't need to know how to read EEGs. You will not be given a picture of an EEG and be asked to describe what kind of epilepsy it is. What you do need to know is that a 3 Hertz spike and wave pattern. So the USMLE likes to throw that phrase out at you. 3 Hertz spike and wave pattern is indeed diagnostic of absence seizures. So if you get a kid that's seen on video EEG or observed staring off into space, and that coincides with a quote-unquote 3 Hertz spike and wave pattern, that is diagnostic of absence seizures. Okay, so just to sum this up, as far as AEDs on the USMLE, there's no musts for choosing an anti-epileptic drug, except for absence seizures, where the first drug is ethosuximide. And note that I say on the USMLE. Okay, so if you're treating a real patient, you better be consulting a neurologist. So I am relinquishing myself of all responsibility. You need to be, a neurologist should be treating epilepsy, should always be consulted in the treatment of epilepsy. But for the USMLE, for test purposes, there really are no musts for choosing an anti-epileptic drug, with the exception of ethosuximide. Valproate is often the right answer for generalized epilepsy, and I would choose it in any kind of epilepsy except for absence seizures. Adverse effects of the anti-epileptic drugs, they're all teratogenic, so pregnant women need to know that if they're on anti-epileptic drugs. More than likely, they're going to want to be taking oral contraceptives. Valproate is the most teratogenic, unfortunately, because it's also the most effective, but it is also the most teratogenic. It also can cause TTP, and that, of course, would be bleeding, bruising, low platelet count. Lamotrigine is often used for epilepsy. That is highly associated with Stevens-Johnson syndrome, which is a really, really bad peeling rash, and it can be deadly. And for this reason, we slowly titrate patients on lamotrigine. Lamotrigine is also very commonly used in epilepsy. It's a very useful drug, but you have to watch out for Stevens-Johnson syndrome, and you should know for the USMLE that lamotrigine is indeed associated with Stevens-Johnson syndrome rash. If a woman is pregnant and she is on anti-epileptic medication, you should never take her off of her anti-epileptic drugs. The risk to the baby of the woman having a seizure is much greater than the anti-epileptic drugs themselves. So they are teratogenic, but they're not that teratogenic. If a woman has a seizure and she's pregnant, that's a much higher risk to the baby just because of the hypoxia than the anti-epileptic drugs themselves. Now, there are certain anti-epileptic drugs that are worse than others. As mentioned, valproate is the worst. Carbamazepine is the best. So if you have a woman that is thinking about getting pregnant and she wants to know what the best drug is, as far as if she wants to get pregnant, then carbamazepine is the one. But you should always be putting her on the drug that best controls her epilepsy. You're not necessarily going to be choosing a drug based on what's best for being pregnant, but that's the facts. In real life, levetiracetam has been shown more recently to be good for pregnant women too. Levetiracetam is a newer anti-epileptic drug. It's also known as Keppra. And then, like any pregnant woman, a folate supplementation will decrease the risk of neural tube defects, and that is actually what the teratogenic effect is of anti-epileptic drugs. And surgery, you may have heard, is a treatment for epilepsy. It is, but it is reserved for patients that have a well-documented focal lesion. So the neurosurgeon is going to want to know exactly where they're going to go in to excise a part of the brain if they're going to be doing that. So you're never going to use surgery as a treatment for somebody with no focal lesion. You're always going to, the only time you're ever going to use surgery is in a patient with a documented focal lesion. And that is it.